Esteemed guests, please welcome to the stage the Clinton Health Matters Initiative Chief Executive Officer, Rain Henderson.
Good evening. So wonderful to see everyone. I am so pleased to welcome you to the 5th Annual Health Matters Activation Summit. Hard to believe that it's been 5 years that we've been convening here in the Coachella Valley around the topic of health improvement. We're so excited about this year's program and so excited that you could all be here. Some of you may remember that in past programs, one of the things that we really feel is important is to talk about what's brought us together. So first, I want to thank our sponsors who have brought us together. So I'm very pleased to thank Tenet Healthcare, who's joined us again for a 5th year as our presenting sponsor. Thank you to our friends and our partner at Tenet, who also do tremendous work with us here in the Coachella Valley that you'll be hearing more about over the next 2 days. I also want to thank the Peterson Center on Healthcare, who has joined us again this year to support the Health Matters Summit. Thank you. And I'm also pleased to welcome Square Roots, who's supporting us for the first time this year, and Technogym, who's a returning supporter. And we also have many other program supporters who are here with us again. And thank you to all of our supporters and to all of our partners. And now to all of you. So yes, another round of applause. Thank you. So now to all of you. So we are honored to be in a room full of people who are invested in the health of others. And I think that is something special. It is something rare. It is something to be celebrated. But we also have an imperative. The onus is on all of us who are invested and who do care to figure out how we're going to do more to help others. And that's why we're here. So those of you who work in health and in healthcare, and those of you who don't, but clearly have an interest and want to do something, that's what the next 2 days are really for us to come together and to talk about. And the arc of the conversation over the next 2 days is that we really start in talking about the data and the science and the trends. We want to make sure that we're rooted in what's really happening across the country in terms of health and health outcomes. So I'm very honored to welcome out in a minute the U.S. Surgeon General, who's known as America's doctor, who's going to talk to us about the landscape of health in the United States. And then over the course of the next 2 days, we're going to move from the data and the trends and really understanding what's happening here and ending on the high note of inspiration and action and talking about what is it that each of us can do in our communities as business leaders, as philanthropic leaders, as community individuals and members to rally together to extend the work that we're already doing and to do that much more to improve the health and the lives of others. And that's really what the Clinton Foundation is so committed to, as many of you has come to know and will learn even more over the next 2 days, is that we really believe that everyone has the opportunity to live their best life and that everyone in this room can contribute to that. So I thank you again for coming here, for believing that it's possible and that everybody can have the opportunity to live a healthier life. And I want you to all welcome the U.S. Surgeon General, Dr. Vivek Murthy, who's going to present a wonderful overview of the health of the United States. Thank you.
Well, thank you so much, Rain, for that kind introduction. And hello, everyone. How's everyone doing today? Yeah? Well, healthy. Well, I'm happy to hear that. Look at that. Someone who's on message. We like that. But I want to just first of all thank all of you for being here, not just for attending this summit, but really for what you do each and every day in your day-to-day lives. I know that many of you have a long-standing commitment to health, and that you're working to improve health in our communities through technology innovations, through new delivery programs, through a host of new innovations. And I just want you to know how much I appreciate that and how important that is, because it's that kind of innovation, that kind of commitment that all of you have to health that makes me think that we have a bright future ahead of us when it comes to creating a healthier America. I want to start this conversation today by stepping back a little bit and thinking a bit about the larger context of health. And I wanted to share with all of you some of the insights and some of the thoughts that I've had over this past year during my first year as Surgeon General. During this year, I've had the chance to travel around the country and to meet people from all walks of life. It is truly one of the great privileges of this job. And in those travels, I've had a chance to sit down and talk to people about what their experiences are. I've had the chance, for example, to talk to parents who have lost children to depression or to drug overdoses. I've had the chance to speak with teachers who are concerned that their students are using e-cigarettes in greater and greater numbers. And I've also had the chance to meet extraordinary individuals who are rolling out healthy nutrition programs and active living programs for adults and kids alike in their communities. And often as I've traveled, I've asked myself the question, how do we create better health for everyone? Not just for a few who are lucky enough to live in the right neighborhoods, but for everyone. And there are four major issues or imperatives, if you will, that I find myself pondering that I'd like to share with you today. The first is I've come to believe even more strongly than ever that we have to figure out how to create a culture where healthy is equated with happiness and with what people want. This might seem obvious, but it turns out that's not the culture we have right now. I know that for too many people, choosing healthy options is usually associated with boring, tasteless food or with onerous gym routines. And I know that not just from my travels this past year, but from years of sitting down with patients in my medical practice and talking to them about lifestyle change. And I saw just how difficult it was for them. But we have to somehow find a way to shift the pursuit of health from being a source of pain to being a source of power. And there are programs, fortunately, which are already starting to do this. Some months ago, I was in Roanoke, Virginia, where I came across a program called the Healthy Chefs Program, which some of you may know. And in this program, they had recognized that many children don't even know what common fruits and vegetables are. And they still wanted to change that. They wanted to help kids look at healthy food as something that was fun and engaging. So they began this program by asking kids what their favorite foods were. And at the beginning, there were the big three that they identified in almost every kid's list. And you can probably guess what they are. But they were pizza, hot dogs, and macaroni and cheese. Now, what the program did is they exposed children to different fruits and vegetables, but they went beyond that. They actually had them work with those fruits and vegetables, make dishes with them. And what they found over time is that the preferences of the kids started changing. Now, the big three didn't disappear entirely, but they were often replaced by fruits and vegetables that the kids had tasted. And it didn't just stop there, but they would go home and ask their parents for those fruits and vegetables. And the school was prepared with instruction for parents on where to get those fruits and vegetables and how to prepare them in a simple and easy way. Through a program as simple as that, they are changing preferences and making healthy eating something that's enjoyable and fun for children. And often what's good for kids is good for adults. And that's something that we have to do all across our country. The second thing that I've come to realize, even more strongly than before, is that while personal responsibility matters in health, the environment matters just as much. When I was an internist in Boston, I took care of a young woman who came to the hospital with a severe infection in her leg. She was in her 30s, and she, for many years, had lived with diabetes, which, as many of you know, predisposes you to infections. When she first started developing infections, they were simple ones that could be treated with oral antibiotics, just a few pills by mouth for a week or so. But then the infection started getting more and more severe. She ended up having to come into the hospital for intravenous antibiotics. Eventually, the intravenous antibiotics were having difficulty getting rid of the infections too, because the bacteria became more resistant. And when I saw her, she had a resistant bacteria that spread to her bloodstream and nearly killed her. Fortunately, she survived. But as I sat down and talked to her, I realized that people had been talking to her about living a healthier life for a long time. They had told her to eat healthy food, not recognizing that where she lived, it was hard to get affordable food, and it was hard to get healthy food. Most of her neighbors shopped, in fact, at 7-Eleven for their groceries. People had also told her in their clinics that she should go walking and get more exercise. That would help her lose weight. What they didn't recognize is that in her neighborhood, going for a walk after dinner put you at risk for getting shot or mugged. And in that situation, she chose safety and her life over going for a walk. These kind of choices are unfortunately far too common for too many people living in our country right now. The environment matters, and when we change it, we can have a profound impact on health. That's in fact what they saw in West Wabasso, Florida, in Indian River County, where some years ago, the county recognized that many of its residents, about 50% of which were living at or below the federal poverty line, suffered from health problems as well. And they realized activity was a problem. So they decided that they were going to invest in sidewalks. They decided to invest in street lighting and cleaning up vacant lots and turning them into parks. And what they found just a couple of years later was that when surveyed, 95% of the residents reported that they had increased their physical activity. And when asked why, they cited most commonly the increase in walkable spaces. So the environment can make an impact on our health behaviors. But perhaps most important to acknowledge when we think about environment is the fact that some of our most important health disparities, a topic which we're going to talk about a lot tonight, some of these our most important health disparities can be traced back, in fact, to the environment. Now, right now, poverty in America, which affects 1 out of 5 children, is too big a determinant of your health. It's something we all know, but something we all have to work towards changing. And poverty impacts access to food. It impacts the kind of neighborhood you live in, which can subject you to not only inactivity, but also violence and trauma. So poverty impacts the environment impacts health. Changing the environment, I know, is not easy. It's sometimes easier to just sit in a room with a patient and tell them, eat healthier and be more active. But changing the environment means pushing back against the forces that advertise junk food to our children. And we know that that increases our consumption of unhealthy foods. Changing the environment also means speaking up for the inclusion of healthy foods in our school cafeterias and in our workplace cafeterias. And changing the environment also means not being afraid to say what science tells us. For example, that drinking soda is contributing to our epidemic of diabetes and heart disease, and that is something that we need to change. Third, I have come to believe that we cannot improve health solely by focusing on the body, but we must also focus on the mind and the spirit. Many of the conversations that I've had with families as I've traveled across the country have been about the costs of depression and other mental health conditions. I've also heard about the growing amount of stress that adults and children are experiencing, and it's impacting not just their health, but their happiness as well. This stress comes from many places, from isolation, from family strife, from economic hardship, from the experience of discrimination. And I learned early on in my medical training that you could put all the effort in the world into figuring out what the best diabetes regimen and blood pressure medicines were for someone. But if their mental health and their emotional well-being were poor, that their ability to even follow through with appointments and take their medicines was often severely impaired. One of the most common things I saw in my medical practice was not just a diagnosis of diabetes or high blood pressure, but perhaps the most common ailment that I saw was unhappiness. Unhappiness that stemmed from isolation, from a lack of meaning, and from a loss of self-worth. But there are ways to improve our emotional well-being and mental health. And we're going to talk about them hopefully over the next couple of days. But the University of Chicago, for example, has piloted a wonderful and intriguing program, the Becoming a Man program, which has been helping young men improve their social connection and emotional well-being, and has actually resulted in a 42% decline in violence. Schools in San Francisco that I visited at the end of 2015 have also been implementing emotional well-being programs and have found that within the first year alone, one of them was able to decrease suspension rates by 45%, teacher absenteeism by 30%. They were able to decrease the anxiety levels of their kids and increase their grade point averages, test scores, and happiness scores from one of the lowest in San Francisco to 4 years later, the highest in the entire state of California. This is the power of what we are already doing with emotional well-being. But fourth, and perhaps most importantly, we have to remember and celebrate that we live in an absolutely extraordinary country. That is perhaps the most important lesson that I have gotten again and again and again as that I visited communities across our country. I've seen that our cities and our towns are full of talent and skill. I've seen that our people are full of hopes and dreams. We have a diversity of races and ethnicities and backgrounds in our nation that rivals anything else that any other nation in the world has. And everywhere I go, I see compelling examples of kindness, of compassion, and of decency. Like the students I met from Jacksonville, Florida, who have decided to take on childhood obesity by creating programs to help their peers eat healthy and stay active. And they've done this not because it's a course requirement to graduate. They've done this because they've seen their peers struggling with obesity and have decided to take it upon themselves to make a difference. I mention this because it can be easy, so easy, to forget just how blessed we are. And it can be easy because our airwaves are filled with voices and headlines that constantly tell us otherwise. These headlines focus on what's wrong with America. They focus on all the reasons we should think that the future is going to be dark for us and for our children. But what these voices fail to acknowledge is the extraordinary good that exists in our communities. And it's up to us as leaders and as citizens to reject these dark views. It's up to us to remember who we are and what we are capable of, and to remind each other and our communities of this, because we cannot cultivate what we do not recognize and celebrate. In closing, the fundamental question that lies before me, and I think all of us, is how can we restore a sense of optimism to our country and to the world? Can we inspire people to choose possibility over pessimism? Without a sense of possibility, people don't pursue change. Without a sense of hope, people are less likely to participate in civic life. And there's this common belief in our nation that we are a country that is built on rugged individualism. Now, translated into health, what this often means is that health is a product of individual decisions that are made over a lifetime, and consequently, improving health is a responsibility of the individual. But securing the health of our communities is more than an individual journey. It will require collective action to change our environments and our cultures in ways that support health. Collective action, I've always believed, when combined with individual responsibility, results in long-term change. And I would say that our greatest moments of a country have been the result of collective action. If you think about it, we fought the revolution together. That's how we began as a nation. If you think about it, the civil rights movement was built and powered by people who came together to bring change to our country. And our response to 9/11 and to countless other natural and man-made disasters that have visited our country since then have been met with collective action. Today, in fact, in my hometown of Washington, D.C., many of our neighbors are digging through a snowstorm and helping their neighbors to clear their driveways and clear their roads. It's collective action. It's by helping each other that we've advanced and had our greatest moments as a nation. America needs a new contract for civic engagement that's anchored in this larger vision of what America can be. Recognizing that our greatest source of strength is in fact our people, we need a renewed commitment to strengthening our country, child by child, family by family, neighborhood by neighborhood. If we do this, I believe that we can create a nation where everything supports health, a nation where people can achieve their full potential, a nation that ultimately our children deserve. Thank you so much, everyone.
And now, please welcome to the stage the Health Disparities Through Technology and Innovation panelists. Chief Health Officer at IBM Corporation, Dr. Q. Rhee. Chair of the Department of Public Health at North Dakota State University, Dr. Donald Warren. Co-founder of Rock Health, Dr. Nate Gross. Inventor and student, Anya Pogarian. United States Surgeon General, Dr. Vivek Murthy. And founder of the Clinton Foundation and 42nd President of the United States, Bill Clinton.
Thank you all. Please be seated. Thank you. Thank you. Lisa? When we were backstage listening to Dr. Murthy speak, I told the other panelists that the purpose of this panel, it sort of is a setup for what we're going to do all day tomorrow, was to discuss whether and how technological breakthroughs could be used to democratize access to quality health care and to speed the transfer of new developments to populations that are currently underserved and maybe harder to reach. And then I told them that they had all done so many remarkable things in this space in their lives already that if I didn't ask them the right question, they should just tell you whatever they wanted you to hear. But we're very blessed. This is quite an amazing panel, and I want to begin by thanking the Surgeon General for his service and for what he said. And maybe we'll get to this later, but one of the things our foundation and this Health Matters project has worked very hard on is developing less expensive, more easily usable, and widely distributed naloxone treatment for people who are suffering from prescription drug overdoses. And it has the potential to do a lot, but the problem is if the non-addicted people who are dying are often people who mix prescription drugs with beer, wine, alcohol, and if they fall asleep, they don't wake up and they're alone. So we need to all be clear about what we can do with technology and what we have to have some sort of personal support system to reinforce. So let me start with you, Dr. Murthy. What is if you could tell us to do one thing, if you could wave a magic wand, what do you think the greatest right now opportunity to use technology to improve public health is?
That's a great question. Let me use this. Well, thank you for that question, President Clinton, and thank you for all the great work, not just on naloxone, but on improving health that the foundation is doing. I think that I'm a big believer that technology has the power to take us where we need to go when it comes to health. And I believe that as somebody who worked on technology for many years before I was Surgeon General. But I think that one of the big gaps that technology can help fill right now is to help connect people to each other so that they can not only improve social connection and emotional well-being, but so that they can share and disseminate innovation more readily across communities. One of the most common questions I get when I travel to communities across the country is what did community X do to help solve obesity? Or what did community Y do to help solve their diabetes problem? When I began my tenure on a listening tour, people knew where I was, before I came to visit them, and they would say, well, what did they tell you they were doing? Because we have the same problem here. And I found very often that even in this age where we feel we are hyper-connected through social media and other technology, communities are struggling to figure out common problems. In Ohio, which ranked at that time a year ago 50th in the nation in African American infant mortality, many public health officials told me that if we could just help connect them with the states that were in the top tier, if they could just figure out what they were doing, that they feel they could make so much more progress in Ohio. So this problem that we have of sharing expertise, sharing experiences, of disseminating innovation and lessons learned, I think is a big problem that technology can help us to solve.
I agree with that, but do you believe there's a general, implicit in what you just said, do you think there is a general predisposition to learn and share?
Well, I think there's a natural curiosity that people have to know what other people are doing, and if they see it as relevant to them, to learn from them. I think that there are some barriers to that. I think, for example, that sometimes some communities I visited think that their problems might be completely different from those of other communities, and that the solutions in other communities may not apply to them. But that's not always the case. More often than not, I have found that communities are quite interested to learn what is happening and what they could replicate.
I could keep you here tomorrow morning on that, but I won't. Just remember, this is a big deal. Some people like learning from other people, and some people almost psychologically as well as institutionally resist it. And it's something we got to get over. If you look at American education, for example, by all international measures, the United States is competitive until about the 5th grade with all other countries. Then the big gap opens up in middle school years, and then it becomes a chasm in high school. And yet, there are everywhere in America middle schools and high schools that are producing globally competitive results in all the common measurements, and there's almost no rush to figure out what the heck are they doing and how can I do it here. So we need, that's one of the reasons for the Health Matters Initiative. We try to get communities together that can first work with each other within the community and then learn from others. So that's very important. Anya, when she was 17 years old, she invented a portable dialysis machine with for $500. The nearest competitor cost $30,000. So she's been trying to spend the last year, I think, trying to figure out what to do with the rest of her life, since many of us go a lifetime and never do anything that neat. But tell us what the current state of play is with your dialysis machine. How many have you produced? What are your plans for it? And what did the experience tell you about the future of healthcare?
That's a difficult question. Well, I started when I was 16 on this project, and I was basically volunteering as a companion to patients on dialysis at a local hospital. And it just sparked an interest in me to learn more about dialysis and understand why it is that many communities don't have access to it, specifically in developing countries, but it applies to the US and Canada just as much. I definitely see that there's a lot of potential in developing a much more affordable dialysis machine, and it would create a lot more of accessibility to these patients that need the treatment to survive. What I learned so much from this experience, not only I had to figure out how dialysis machines function, and it is a complex process of filtering blood, but also understanding what the barriers are in many communities, and understanding how to simplify the technology to really make it more accessible. So that's very much what I learned from this project.
Tell us how the performance compares. I mean, I read in the materials getting ready for this that your machine will filter 4 liters of blood in 25 minutes. Is that accurate?
That is accurate. I had the opportunity to test it out at HEMA Quebec, which is Quebec's blood donation organization, similar to the Red Cross. Basically, we had a whole team of researchers that put their work on hold for 1 week to help me test out my device. So that was an incredible opportunity for me. And that is when we tested it out with the blood of 8 donors, the equivalent of 4 liters. So, and it did take only 25 minutes to filter.
So how does that compare with the performance of the $30,000 machine?
Well, a typical treatment is about 3 to 4 hours on dialysis. And in this case, it was much easier to filter it. I guess I'm not entirely sure why it was so much quicker, mostly because we used a bag of blood as opposed to like a patient who it's much more vascularized, and it's more difficult to access all the blood at the same time. So for that reason, it was 25 minutes. I would have to do much more testing to really answer that question.
Are you trying to develop it so it can be mass produced?
I'm sorry?
Are you trying to produce more of them, I mean, so they can be distributed?
That would be, of course, the end goal, to put it on the market. But I definitely would like to build a third prototype. So I've have 2 prototypes so far, a third one and possibly a fourth one to really improve it and make sure the technology is really like to par with the typical devices.
You know, we've had our foundation, this project, has been involved in several codathons with young university students around the country, trying to figure out how to solve various problems. Do you think that's a useful exercise, and should we do more of it, and what would your recommendation would be about that?
Absolutely. I think that innovation should be part of the learning process, and it should be, if you have an interest in developing devices or just innovation and technology in general, it should be part of the school system, I believe. That was a huge challenge for me, just combining the project and school at the same time. So I think that it should be much more accommodating for students that have the willingness to try and do something different, because there is potential.
Dr. Gross is the co-founder of a company called Rock Health, which funds seed and early stage venture capital for digital health startups. So I sort of wanted to codathon to set it up. And I asked him how he was doing, and I wanted him to talk to you about it. And I said, did you have any trouble raising the money? He said, yeah, at first, because there was no proof of concept, but now they're doing well. So talk about that. We can talk all we want about all these breakthroughs, but we got to have some mechanism to take them to scale and distribute them. So describe to people the space you're trying to fill and what your experiences are.
Sure. Well, thank you for the question. I work at an organization called Rock Health and came into that from medicine and from starting another company called Doximity and learning the challenges of both being a doctor and being an entrepreneur in healthcare. About 5 years ago, that was really hard. And yet, I think the opportunity is phenomenal. Dr. Murthy touched on a point around connection. I think the opportunity for startups is now to build on that connection and have positive feedback loops that bring in really meaningful change. We've supported so far about 50 companies through Rock Health that are doing just that. Rather than talking about the investing side, which is the boring side, what they're doing, the exciting side, we have companies like Omada Health, which you'll hear from tomorrow, which focuses on pre-diabetes, communities with pre-diabetes and preventing the progression to full-on diabetes, Kerbo Health for childhood obesity, Wildflower for healthy pregnancy, Lantern for mental health and anxiety. We have what I work on, making sure that physicians, when knowledge historically takes 17 years to disseminate through this system, and all the great things that the researchers in this room come up with, stumble to actually turn that into meaningful practice and massive change. I think there's a solution for technology there, and I think there's finally a solution for technology to improve the rates of error that we have in this country. Folks at the Joint Commission have estimated that if miscommunication was considered a cause of death, which is the largest source of medical error, it would be the 5th leading cause of death in this country. Every single thing there, I can see light bulbs go off in the room of this audience. You realize, you know what, there's an easy parallel to what I did this morning, checking Facebook, using an app, a meaningful way that we can interact with one another through technology to bring about change. And that's what we support at Rock Health. So what I'm excited to see for the next few years is an increase in the concept of literacy, not just literacy on do you know how to take your medication, but literacy for everybody in this room, whether they're from a government position, a large corporation, a startup. You know, if you have a lot of peers doing hackathons, I think that's great. What that does is it gets someone excited that they can actually get into healthcare. And it becomes legible. It's not just a moon language that we all speak anymore. And so we hope that maybe that next Mark or Melissa Zuckerberg will actually be excited about doing healthcare. And we can come in then as a community in this room and give them what they need to feel like a team of 20 instead of a team of 1 or 2.
Thank you. I just want to ask, you can comment on this if you like, but when I read about the work you're trying to do, it struck me as, if it works, is potentially very significant because before coming here, I was in Irvine for the 4th annual patient safety seminar that my friend Joe Chiani and a lot of other people have worked on now. Their goal is to try to eliminate all unnecessary hospital deaths by 2020. And they went from, and they have some independent group come in and measure the data and tell them how they're doing. So the scorecard for 3 years is 600 to 6,000 to 24,000 as they get more and more partners. And he is a medical technology director. He made his way in this space with non-invasive technology to analyze blood and things like that. But he said to me, I feel like now I've run up against an old-fashioned organizational problem. I don't think we'll ever make the time deadline because I don't think I can organize enough players. It was very touching. I mean, there were people there from all over the world too. They're really excited about it now. And I mean, it's not like he's not doing well. And if you look at the trajectory of Promise, and he always has independent people validate his numbers, it's impressive. But he did say that to me. He said, "Here I am. I made my start in this in non-invasive technological developments, and now I feel I've got to actually organize real bodies in real places and real hospitals with real, tactile things, and I'm just afraid I can't do it." Can we do more technologically on that, in that very space? It's basically avoiding avoidable deaths, reducing them, eliminating them. And what is the role of technology that has not been deployed in this space?
Well, the good news is the world has changed since then, and it's really just changed over the course of even the past week in the rate that the players involved are adopting technology for other reasons that can be used for healthcare. So we have 3 billion people online now. Thanks to this device in my pocket, 90% of US doctors have an iPhone in their pocket. And the ability for them to then connect with one another quickly, for you to be able to quickly reach someone else that you need to actually bring about some element of your change, I don't think existed a few years ago. You also have the reach through patients. They're going online at similar rates. 1 in 20 Google searches is now about healthcare. Google's recognized this, and they show right in the sidebar now, when you type in a disease, a piece of meaningful information so that the patient isn't exposed to some sort of advertisement or something like that. And so I think that as hard as we're going to work on solving these problems, building these partnerships, that is exactly what Rock Health does. We make sure we have all the right people in the room to get you started. What's really going to move the needle is these greater forces at work of adopting mobile and online tech.
Well, we'll move next door to what ought to be your next target. Dr. Don Warren is the director of the Masters of Public Health program at North Dakota State University. He is a member of the Lakota Oglala Sioux tribe, whose headquarters is in Pine Ridge, South Dakota, and I've spent some time there both before, when I was president, and since then. And he can tell you all you need to know about the disparities in healthcare between Native Americans who live in rural areas, especially those that have no access to massive gambling revenues, and their relative vulnerability for things like type 2 diabetes for genetic reasons over and above the environmental factors that are making it a problem everywhere. So he's literally spending his life trying to prepare young people to go out in places that feel left out and left behind, to populations that are radically underserved, to practice public health in the best sense. It's what he does all day, every day. So tell us what you think would help you most in terms of these technological developments. What do you need most? What would save the most lives? What would give the largest number of bright futures? What would you like to come out of this that you can deploy in your quest for better public health?
Well, first, I would want to thank everyone for ensuring that the American Indian issues were at the table. So that's not always the case. And unfortunately, as American Indians, thank you very much. And unfortunately, we have terrible health disparities, and the disparities are typically written in a report and put on a shelf somewhere, and we don't really do anything about it. So when I think about the need for accessing more technology, we have to take a very holistic approach and recognize there's not going to be any single thing that we do that's going to make a big difference. We have to operate at multiple levels. So just to give you an idea of some of the disparities, in the state of North Dakota, American Indians' average age at death is 54. It's 75 for the non-Indian population. And what I tell my colleagues in higher education and public health is that you do not have to cross an ocean to find third world health issues, third world health conditions. It's right here in the US. And unfortunately, our issues as American Indians have been largely ignored. We have a very small population relative to other populations, and the result is our issues are not focused on. Now, in South Dakota, where I am from, particularly in Pine Ridge, South Dakota, that really is in many ways the epicenter of health disparities in this nation. The average age at death for men from Pine Ridge is now 48. 48 years old. So again, we don't have to cross an ocean to find third world health conditions. It's right here. So the way I've tried to approach this, I've worked in a number of different settings. I've been a primary care physician, and what I found is I was really a diabetes technologist as a primary care doctor in Indian Health Service, and just writing the same prescriptions for the same disease issues that we're trying to deal with, but not working far enough upstream to prevent things like diabetes. And when I think about some of the challenges that we face, much of it is just simply accessing services. And there are simple technologies that would go a long way to improving quality of life. So for example, if someone is eligible for Medicaid, they're probably eligible for certain social programs or housing programs or other financial assistance programs. Why do we pretend that people don't have smartphones? Or why do we pretend that people don't know how to use an iPad? And why don't we have a simple technology to enroll people in everything they're eligible for? Why do we make people with limited transportation drive 75 miles to a county office, and if they're... And in truth, if they're American Indian, quite often they face racism when they go to that county office. And why do they have to go to different locations to sign up for services? To me, that would be an incredibly simple technology, much simpler than a dialysis machine, I would venture to say, to just have a universal services enrollment process. That alone would be low-hanging fruit that would do a dramatic amount of good for people, not just American Indians in rural communities, but why don't we just use the simple technologies as they should be available to us, just to have access to services that already exist.
I think it's interesting, for more than 15 years now, your government has been only too happy to let you file your taxes and pay them online. The least they could do is turn it around. I mean, I'd say we did that. We got some sort of award from Inc. magazine saying the Social Security Administration and then the IRS had among the best customer service in the country when I was there. And all we did was basically give people, a website. So it was, they weren't used to, back then in the Stone Age when I served, they weren't used to having 24-hour service. But it sounds simple, but it wouldn't be that hard to make an app for all this to happen. So I thank you for saying that. And I invite all the rest of you to remember the numbers he gave you. And the work that we've been doing for years in our schools and with trying to reduce the sugar and calories going to kids in schools from soft drink, trying to improve the meals, trying to improve the exercise programs. The thing that struck me the most, and we were talking about it on the way out here, was a study I read, which I have never seen contradicted, which said that given a constant rate of diet and exercise, good or bad, across racial lines, European Americans were the least likely to get type 2 diabetes. Hispanic Americans were 1.6 times as likely. African Americans 1.8 times as likely. Native Americans and Pacific Islanders twice as likely. And I don't know if that study's ever been contradicted, but it certainly is consistent with what we see in the school districts where we work. And if that is true, then all these like new food guidelines and all this stuff, all that should be taken into account. And technology ought to make it relatively simple to figure out how you would change a weekly dietary recommendation that would have no impact on the school district's cost. And a number of other things. So I ask you all to think about this. You know, the biggest public health problem we have now, I think, is the opiate and heroin problem that's sweeping across small town and rural America. But don't forget, this diabetes thing it's taking down life expectancy, and my guess is it is a big reason for the numbers that Dr. Warren just gave us. So he's asked us for an app that allows someone to do one thing and do everything at the same time. And it bothers me that we don't do more of that in America. After the earthquake in Haiti, we learned that only 15% of the Haitians had any access to banking before the earthquake. So everybody got their cell phone back, and we got a Canadian bank, Scotiabank, to partner with their cell phone company, which was owned by an Irishman. And all of a sudden, 80% of the Haitians had access to basic banking, had bank accounts and services. And it had a huge impact on the daily life of people. Also had some health implications, but I won't bore you with it. But I'm saying we ought to be able to have an app which does that for the Native American populations. And I thank you. Give him a hand. Dr. Reed's had an interesting career and has a fascinating job for IBM. And it seems to me that what the company has asked him to do basically puts him at the center of both technological developments in modern medicine and how to distribute them, but also how modern organizations should be set up to deal with every aspect of this issue. So I'm just going to ask you, first tell them briefly what you did before you became in charge of all this for IBM. Then explain the sweeping nature of your job and what you've learned that could be put into the rest of the population to advance the public health.
Thank you, Mr. President. So a little bit about myself. So I am a primary care physician. I trained in internal medicine and pediatrics with the interest in serving in underserved communities. As a National Health Service Corps scholar, worked in the Washington, D.C. area, and worked at a community health center called Unity Healthcare, which had a very underserved population. If you look at one of the great successes of our healthcare system, the community health centers are a great story. Right? Yeah. So just a quick bit about that. That experience made me very aware that my medical training and my residency didn't really prepare me for really what matters, which is health. That it prepared me to know about health care and the diagnosis of disease, the treatment of disease, the medications that I needed to know about. But frankly, when that 15-minute visit, when you got 40 charts at the beginning of the day that were all in paper-based settings, those textbooks that were behind me, the journals, I mean, frankly, it was extraordinarily challenging to address those broader determinants of health, the social determinants of health, and also the healthcare issues. But I think fundamentally what's exciting is those relationships that you build and that those community health centers and the people working in those settings build, working with community health workers, working with a broad range of team members. Healthcare is very much a team sport. But I want to highlight the fact that you realize that it's so challenging, it's humanly impossible for any person, any physician, to know all that data, all that information that's in those charts, that's in those textbooks, that's in those journals, as the medical literature doubles every 5 years and the medical kind of data doubles every 73 days. So there's an extraordinary opportunity to think about how you can translate big data to big insights. So from there, I worked at the federal government, so was very interested in health disparities, worked at NIH and also HRSA, the federal agency that looks at community health centers, looks at the National Health Service Corps, the Ryan White program, and also maternal and child health, and was very fortunate to look at health disparities at a national level and to look at the opportunities when you think about the different stakeholders in the healthcare system and the role that all those stakeholders, I like the story, if you're not at the table, what are you? Probably on the menu. So the importance of bringing all the stakeholders together to think about health and healthcare and realize that healthcare is only 10% of health outcomes. So that was an extraordinary experience looking at the Affordable Care Act and working with all those different stakeholders that have such a desire to that common goal of healthy populations. And now for IBM, my responsibility is in two primary areas, looking at the culture of health that we as a company with 400,000 employees need to assure that that value is sustained throughout IBM, wherever we are across the globe, but also looking at our strategy around how we can translate big data to big insights. How we can now leverage that data that was in those charts that's now digitized in ways that we can all access. And a tool like Watson, has anyone heard about Watson? Okay, in Jeopardy? So the ability to have a tool like Watson that can read 80 million pages a second. And we have to realize that opportunity to bring that data from those textbooks, those journals, the electronic medical records, and actually wearables, for example, and to recognize that health is so much more than health care. I like to use the acronym housing, education, access to healthy choices, labor and employment, transportation, and a holistic view of health, which includes health care. And the reality is now we can connect all these data points and really start to create intelligence that can bring insights to the key stakeholders to nudge them to make the right decisions that can both predict, personalize, and prevent disease. So.
Let me ask you, and maybe Dr. Murthy, you'll have something to say about this. I love what you said, but I want to ask you something mundane. I mean, compared to what you said, because of IBM's great capacity and your obsession with getting good, reliable, retrievable records. And all this debate over the Affordable Care Act and where it should go and what we should do and everything. One of the things I think has the greatest potential to do good is the development of new payment systems that are basically all-payer systems where you pay for performance, not by procedures. But the details matter. You agree with that? Oh, totally. Okay, so I have been intrigued by the success of the Geisinger Medical Group in Eastern Pennsylvania. And they just got a new leader who came from, he was the dean of one of the big medical schools in California. And they have basically a very simple business model where they thought they would actually make more money by improving people's health care and spending less time with them. But part of the deal is if you join Geisinger, now you have to have a large number of doctors because they can, do whatever. And if you're in the hospital, if for any reason after you're released, you go back after, I can't remember if anybody here knows the details, feel free to correct me, but it's somewhere between 90 and 150 days. For any reason, if you have to go back related to the condition for which they treated you, they eat all the cost. And no cost can be passed along to you in the form of higher premiums, higher copays, higher deductibles. as a result of which their medical error rate has dropped to almost zero. And the way they do it, so this is the way they do it. I was going back to the whole deal about technology and physical organization. They have a center in their practice group that every single day reviews all this mountain of new information coming up. And that for each condition they can even imagine treating, every single doctor has a massive book with the latest best practices. And their basic theory about medicine is take the science first and then the art. And so that everybody promises to go through, the best known practices. And then if you get Bill Clinton and he's a bleeder or something, then you're on your own, you figure out what to do and do something heroic, hopefully. But you get it. And the point is, it's been stunningly successful. More people enrolling, more doctors are being hired. And the people who were there from the beginning told me at first there was this enormous reluctance on the part of doctors who were 60 or over to do it. The people who just got out of medical school, they said, sounds good to me. But they created a common culture that basically is take the best science first, then the art if you need it. Isn't there some way I don't think they have a copyright on this, and I don't think they'd care, but why aren't we doing something like this for all the medical providers in rural healthcare all across America? Why doesn't everybody have access to a constantly updated book like that online?
So, Mr. President, you were talking about the importance of the fact that the healthcare system is shifting from volume-based to value-based. And I do think the devil's in the details about what that value is and how you quantify, or particularly the topic of quality, I would say. Because if you look at us in the US, it's $3 trillion that's spent in healthcare, and there's about 300 million people. So each of us is contributing, on average, $10,000 to the healthcare system, which is really unsustainable with a 5 to 6% increase. And so if you think about it, me and my wife and my dependents, 4 people, it's $40,000 that's going to healthcare. So it has been primarily volume-based. What we've been looking at as we look at the data, and we see a lot of the focus on the quality piece of volume-based is actually in tertiary care. And I would suggest that there's extraordinary opportunity to improve in that area. This is in the area of hospital-acquired infections, readmission rates, a lot of these measures that matter that are in that type of hospital setting. But I would challenge us to think about going further upstream, as was referenced earlier, and think about early detection, and think about primary prevention of disease. And frankly, physicians, are an important part of the tertiary care equation, and there's room to improve with evidence-based guidelines only being 50%, medication adherence rates only being 50%. There's much room to improve and focus there. But I think we have to challenge our physicians all across the country who are a key part of this equation to think further upstream. And many doctors aren't trained. You want to clap? Go for it. Come on. Many physicians, frankly, aren't trained to know how to promote healthy eating choices, active living. In that 7-minute visit where you're trying to figure something out, and you've got all these cross-cultural issues, especially with cross-linguistic issues and disparities issues, you don't have a lot of time to address those broader determinants of health oftentimes. So to me, I would challenge, and we do challenge, with the data, there's extraordinary opportunities to connect data pieces and to get insights that can help hopefully predict and personalize and prevent. And I think you made a good point. All that data that exists in the textbooks, that can be on a cloud, that can be on a mobile phone, that can be an iPad, and clinicians can get what we consider augmented intelligence to support them to nudge the right decision. We're doing that. IBM is doing that in India. We're doing that in Thailand, where all the great knowledge of oncology care is accessible to clinicians in that setting who typically don't have access to that knowledge. But there's got to be also recognition that health is more than health care, and that 1 hour that you typically spend in a waiting room and with a doctor for 15 minutes, we've got to be thinking 24/7, 365.
One of the greatest race car drivers in the history of NASCAR. Jeff Gordon just retired. He's a friend of ours. My daughter and son-in-law and granddaughters they have an apartment in the same building. He lives in New York. He gave me $1.5 million to build a cancer center at a hospital called in Butaro in Rwanda when Partners in Health and our foundation were finishing the work of rebuilding the health system after the genocide. And I was struck, because St. Jude immediately puts online any results of any genomic analysis they do and any advances. That here are these people in Rwanda with immediate access to good information and in far more common kinds of maladies that are driving your life expectancy so low. We're not making more mundane, but maybe more life-saving information regularly available to people in rural settings for underserved populations. That's why I asked you that question. And I think that's accurate, don't you?
Yes.
So, Mr. Surgeon General, what were you going to say?
Well, your question, I think, is a really thoughtful one, and I think it goes even deeper than the data, a question of how we share information and more information more readily with doctors. I think what we're really talking about is a more fundamental culture change that has to take place within medicine. Because right now, doctors are trained to treat illness. They're not trained to prevent illness. And as a country, if we look at how we invest our resources, whether it's from CMS in the government or just in the private sector, we invest the lion's share of our resources and energy in treating illness, not in preventing it. I think changing that will require shifting culture, and the financial incentives you mentioned, the type that Geisinger and groups like Kaiser actually focus on, I think are a step in that right direction. But I think the key is, in the Affordable Care Act, which you brought up, there were demonstration projects around setting up ACOs, accountable care organizations, where the goal was ultimately to get institutions like hospitals to focus more on delivering better outcomes as opposed to quantity of care. But recently, in the last few months, CMS announced that they're the Center for Medicare Innovation, in fact, that they are investing now in accountable health communities, which are, if you think about rewarding a hospital for better outcomes, think about rewarding a community for better outcomes. And that is actually, I think, the direction that we have to move in, because the truth is that if we really want to prevent diabetes and reduce rates, that we have to not just change what doctors are doing, but we have to change how other institutions, non-health institutions, are thinking about how they're providing food choices to people, how they're making cities more walkable. And this is, I think, one of the tendencies that I worry about in our country is I think that we are pulled sometimes to complexity. We're trained somehow to think that complex problems always require complex solutions. But when you think about complex problems like diabetes, it turns out that if you could get people to walk on average 22 minutes briskly each day, you could reduce their likelihood of developing diabetes by 30%. It turns out that if you can help improve social connection in a community, that can extend people's lifespan, because isolation, it turns out, can reduce your lifespan nearly as much as smoking can. There are things that and if you can also increase your fruit and vegetable intake just by 1 serving a day, that can have a measurable decrease in your risk of having a cardiac event over the next year. But changing those is not something that doctors or even hospitals, I would say, are trained to do. So if we really want our physicians and our nurses to be agents for change when it comes to health, for actually preventing illness, not just treating it, I think we have to rethink not just what information we give them, but what role they have. The doctor of the future, for example, may not solely sit in a room and see a patient in a clinic and counsel them about health, but they may spend some of their time identifying the root cause of their patient's diabetes or risk for diabetes and working with the YMCA or with their employer or with their faith organization to change the environment that can ultimately have a powerful impact on health.
That is, he gave us a lot to chew on. But the one thing I think is really worth remembering for all of us when we go home is that having the right kind of human interaction can make you more resistant to some sorts of illness and increased lifespan. And a couple years ago, I took, I don't know, 6-8 months and read everything I could read about societies with a lot of centenarians. And I read one book which said that the highest percentage of centenarians was in Okinawa among those who didn't go to the American military bases fast food places. But that the second highest was on the island of Sardinia. And they said, you know, they're Mediterranean diet, they go to bed with the sun, they get up with the sun, they got even hillier than Okinawa, they work hard, blah, blah, blah. Then they said, but there is this study about all these Sardinians that moved to Pennsylvania near the coal mining country so they could go to work, and they like living up against the mountainside. And as soon as we were there, they adopted our less healthy eating habits, and their life expectancy went down, but less than would be predicted, because they still had such tight intergenerational personal contacts that they still had a higher life expectancy than everybody else around them. So there is like a lot of evidence to support what he's saying. Now, Dr. Groth, what would you do if Anya came to you and she said, look, I developed this dialysis machine for $500, and the competition charges $30,000, and I process 4 liters in 25 minutes, and that's pretty damn fast. So will you or will you not fund my expansion to produce 100 or 1,000 or 2,000 of these? Now, I'm saying, obviously I don't want you to say yes or no, although I'd like you to say yes, but explain, I mean, this is Exhibit A. You got a brilliant young person who figured out how to do something that either hadn't been done because people liked the profit margins in a $30,000 machine, or because they really didn't know how to do it. She figured out how to do it. That's basically what you're trying to support, isn't it? Rapid medical. So how would your company analyze whether and how to finance what she did so you could take it to a larger scale and send it out to Pine Ridge?
Well, it's a great question, and this isn't Shark Tank, so won't be making any investment decisions tonight. But what we support is early stage funding, and it's high risk. You have to accept that if a lot of your ideas aren't failing, you're probably not pushing hard enough. If you want to bring massive change to the system, you have to bet big. You also have to bet on the people, because you expect that ideas change and evolve over time, but the people don't. And so you really have to make a choice early on that founder. And then finally, you have to think about the philosophy. You know, we don't have the spreadsheets up right now or anything like that, but the philosophy behind what they're doing. I can think of another investment we made that has a very similar philosophy to yours, and it touches on what Dr. Murthy was talking about patient-doctor FaceTime. And that's a company called Augmedix. Augmedix uses the Google Glass, and they're the only Google Glass startup that we've ever invested in. Most people that come to you with something like the Google Glass, they say, hey, this is a new technology, let's stick it in there. That adds to the cost of the system, right? That doesn't make things better for people. But what Augmedix did is they realized, hey, you know what? When you guys interact with your doctor, I know this has happened to me recently, I didn't actually interact with the doctor. I sort of looked past his iPad or her computer as they were typing in everything that I was saying to them. That destroys the patient-doctor relationship, that eats up really valuable time that we could be using coaching healthy behavior and healthy habits, missing really important things like depression or ED that they might have come in with. So instead, by leveraging this technology, leveraging the Google Glass, they're able to not actually have to be in that computer writing the chart. That's taken care of for them. Meaningful information is beamed right to their eyeballs. And so it's technology that actually decreases the overall footprint of technology in healthcare. Just like your device actually is cheaper, smaller, more nimble, more agile, decreases this overall technology burden on the system. And that's actually the philosophy that we're looking for. It's not technology for technology's sake. It's technology for making healthcare better for everyone. And so you would immediately get that checkbox.
Thank you.
So what should she do if she wants some money? No, I mean, literally describe what, like 3 or 4 things right off the top of your head that you'd want to know before you decide whether to try to finance a substantial effort to take this idea to scale. one, does it work, right? So assume it works. Assume everything I said is factually accurate. Then what do? What are steps? No, it's a good assumption. What are steps 2, 3, and 4?
Oh, it's
It's
great.
important for these people
It's
to hear
really important.
how you analyze this, because you're doing something that is obviously pivotal whether this whole thing ever works out or not.
So not only do you have to know, does it work, you also have to know, does it work in the eyes of people that control healthcare in this country? So, if you need to go through the FDA or something like that, you have to make sure that you get all those things checked. And that's gotten easier and easier. We have a network that helps our entrepreneurs get through that process. Then you have to talk to somebody along that value chain and decide if they would use it. You have to have user-centric design. And so now you mentioned a lot of people here wouldn't want a device like this to exist. It would cut into their business. But some people would. Maybe they're the nephrologists. Maybe they're the people at the hospital caring for these patients. Maybe they're a smaller dialysis company that wants to adopt this technology to beat out their competitors. So we need to find someone else that would say, yes, this is something that I would start getting, I would buy, I would integrate. Because we don't just support it for charity's sake or for research's sake. The stage that we're at needs to create a sustainable business. And without sustainable business, you're not going to get to the scale you need to achieve meaningful impact. And then finally, we bring in everybody else. We don't just have generalist doctors like myself review it, but we would have Mayo Clinic nephrologists or Kaiser Permanente nephrologists, folks from our partners who could come in with meaningful expertise and give suggestions. Often, you're not just looking to pitch to sell, but you're looking to get advice on how do you take it to the next level. And so it's an exchange.
Interesting.
Get your application ready. We got to end up, but I want to give Dr. Warren a chance to answer this question. If you've never been on the Pine Ridge Reservation, it's hard for you to imagine what he said. But there are amazing people out there, and they live with astonishing dignity under the most undignified conditions. So if you could have one thing, if you could have everybody in this room, and you don't know anything about their background or what their resources are, if they could do one thing to improve public health in Indian country, what would you ask for? What would you do?
I wish there was one solution. I do. I wish
No,
there
that's the
was.
point you made before. I'm giving you a chance to make it again.
There's so many challenges, and just even thinking about the discussion regarding the fact that we don't prevent disease in the doctor's office. That's done in the community. And even looking at disparities in diabetes and even in kidney failure. It's remarkable. In many of our reservation communities, the newest, nicest building is the dialysis center. And we need the technology. We absolutely need it. But what if we invested in preventing diabetes in the first place? In my hometown in Kyle, South Dakota, the gas station doubles as a grocery store. So if you want to purchase food, it's what can be stored on a shelf for a long period of time. There's a little cafe there, and I think what they've learned is that you can bread and deep fry just about anything and serve it for lunch. There's a small section where you can purchase fruits and vegetables, and I won't say fresh fruits and vegetables, but there's a concept in public health called a poverty tax. And it's not a real tax, but when people live in impoverished communities, they pay more money for fresh fruits and vegetables. So people have less resources, but they're charged more to purchase healthier foods. So is there one thing? No. There's hundreds and hundreds of things that we need to do, but we need to recognize that it's a problem. And we invest so much money in dialysis and in amputations and in heart bypass surgery and all of these outcomes from diabetes. Wouldn't it make more sense to invest in healthy food in the first place?
Doctor, the reason I was so pleased you agreed to come here and so interested that you took the job at IBM is because of your background in public health. And we didn't really get into this, but just from reading your job description, it appears to me that perhaps your primary responsibility is to make sure everybody who works for IBM is in a whole system that makes sense and that deals with all the things you just talked about. And it's a pretty amazing company with a lot of obvious resources, financial and technological. I guess what I'd like to ask you is how satisfied are you that you are implementing the very finest holistic use of technology and prevention and environment for the larger IBM family? And secondly, what happens to all the people that don't work for a company like that? That is, how quickly can we realistically take, assuming you get this done the way you want, do you think it will lower IBM's health bill? Do you think and improve IBM employees' health? And then will there be a model there that we can use to do it for the society as a whole?
So those are great questions. I wanted to make sure that people knew that I talked to Anya in the green room, and I did offer a job at IBM, just so you know. One thing, a company like IBM that's been around 104 years, just think about it, calling itself International Business Machines 104 years ago. I think one of the key aspects of companies like that, like IBM, is that you have a culture of health, that you recognize the importance of your workforce and the investment that you need to make in that workforce to not only be productive and high performing, but it's just the right thing to do. And it does reduce healthcare costs and address other issues. So I love the fact at IBM that we do think holistically about health. So yes, it's physical. Yes, it's mental. Yes, it's social. If you look at IBMers, one of the greatest strengths that they have is this social connectedness, the relationships they have amongst each other. How many companies have a term that signifies, that you're associated with a company, like an IBMer? Financial and purpose. And IBMers have often that strong sense of purpose. And so what I love about IBM in our current moonshot, as we call it, as Ginny calls it, related to healthcare, Watson Health. We had a debate within IBM, what are we going to call it, Watson Health or Watson Healthcare? And we came up with health because it was clear that this wasn't just about healthcare. It is about transforming healthcare, but it's also about addressing health and promoting healthy populations. So there's two major pieces that I would highlight to the audience that's important here. Think about, the Robert Wood Johnson Foundation often talks about, where people live, work, and play. Think about where you work. Think about what role can you play to activate or to promote a healthy environment, a culture of health. Think about all those choices that people make, that decision makers within your company make, and how can you nudge those choices? There are things I'm extremely proud about at IBM. We've eliminated pre-existing disease exclusions in a number of sub-Saharan countries where we have employees, like things like HIV. We've added maternity care in places like the Philippines. We've added so many policy changes that really help advance the health of the workforce, and that by nature, the competition looks at us and says we need to implement those changes as well as a large employer or as an employer to be competitive with IBM. So, think about that. So think about that culture of health. The other piece is think about the role that information has and how that can play a role. Because right now, what currently exists in health and healthcare is all this data is stored in silos. It's in systems of record. And there's extraordinary opportunity to leverage those silos. And there has to be trust. Remember the stakeholders I was talking about and being at the table? The different stakeholders have to trust each other because data sharing doesn't come easy. It comes with trust. And the opportunity in sharing that data and this concept of even data philanthropy is to translate and make those systems of record into systems of insights that can help each of those stakeholders advance the ultimate goal of healthy populations.
Thank you. Did you want to ask a question? We've got to go. We're way over time, but she's been holding her hand up, so I'm going to let her ask a question.
Thank you very much, Mr. President. My name is Dr. Mona Khanna. I am board certified in public health and preventive medicine, occupational medicine, and also internal medicine. So I can appreciate everything every one of you have said, particularly your last comments about you spend most of your waking hours at work right? It should be a culture of health. But that wasn't my question. So what I want to say is something that you touched on a little earlier, and that is there are so many special interests in health. It's really not just about the doctor and the patient in the room. There's special interests who will never, ever want to help you get your $500 machine up and running, okay? There's special interests in the use of salt in foods. There's special interests in continued use of unhealthy foods. There's special interest in making sure that the food deserts that you talk about will continue to exist. So it's never as simple as we want it to be. I would love as a physician to talk to my patients and have them absorb everything that I have to say to them and help motivate them to health, but it doesn't work that way. So I love all the data and the analysis. I've been to 1,000 conferences myself. I understand digital applications and all those kind of things, but really what it comes down to is how do you motivate people to make the changes, not just in themselves, but teach their children. All of these electronic and digital apps that we're talking about are great, but we're going to miss a huge section of the baby boomers that are out there now that don't understand how to program their iPhone. What about those guys? So how do you motivate people? How do you get all of these special interests out of the way to help the changes happen that we all want to see happen?
Well, Mona, that's a really wonderful question, and there were a bunch of questions in there, so let me just take a couple of them. One on how to deal with special interests. You're absolutely right that there are, regardless of how, sometimes we don't like to talk about it, there are industries and companies that profit off of keeping people unhealthy. We have companies that advertise junk food to our kids, that push soda into our school vending machines, that want essentially unhealthy foods to be everywhere because it drives a profit margin. But the truth is that I think the only way we're really going to effectively push back on those forces in the long term is if we mobilize people in communities to speak out for what they actually want. Now, that might seem like an old romantic idea of grassroots activism or democracy, but I actually think that it's effective because I've seen it work. Clap for grassroots activism, it's important. But just a few weeks ago, I was speaking to a group of mothers who got together and were upset about the fact that the restaurants in their neighborhood offered soda on all the kids' menus. And so what did they do? Well, they banded together and they went to those restaurants and they demanded that they take soda off of the kids' menus. And they were successful. They did the same thing with advertising junk food in schools. They were upset about the fact that schools were allowing the advertising of junk food, whether it was sodas or other beverages. And they collectively came together. They worked on the school board, they worked on the schools, they worked with the city government, and they got junk food advertising out of their schools. That hard work of grassroots activism, that's not easy. It takes time. It takes people doing work sometimes outside of their day jobs. But it is, I believe, how we've made the most important sustainable changes in this country. I wasn't alive during the civil rights movement, but from the folks that I have had the real blessing to know, who were part of that movement at that time, they tell the stories very clearly of the fact that there were many people who didn't think that the movement would happen. There are many people who said this problem is far bigger than any one of us can solve, or even that a whole group of us can solve. But it took large numbers of people coming together to demand that kind of change that ultimately pushed large swaths of society and ultimately the government to move. So I think that we can't underestimate how important it is to engage people on the grassroots level in the process of change. And as important as we must work from a grass tops level, as important as technology is, as important as policy change is, I think when we leave people behind is when we get into a danger zone. Because policy that moves forward without the support of people, I think is in danger. It's not sustainable.
Let me just say, I'm going to call a halt to this because you guys have been really patient and our panelists have other things to do with their lives, but I'd say it'll dawn. But we have here the person who runs our community health project and the person that runs our effort against childhood obesity, the Alliance for Healthier Generation, Dr. Hal Wexler, he's here. And I wish you would give one of us your card, because the truth is, there's not just one thing that works. For example, in 90% of the schools, we succeeded in reducing the total calories shipped to the schools from drinks, not just soft drinks, but also processed fruit juice, by 90%. And that is not according to me, but according to 2 independent surveys. We were able to do that by convincing the large manufacturers of soda pop and juice that they could make money in a different way by getting out, flavored water and all the other stuff. We don't ask them to lose money. We just say, if you do this together, you can actually save these kids' lives instead of giving them diabetes. And then they'll still be able to buy a soda pop when they're 35 instead of being in a wheelchair. And no, really, I mean, I don't want to be romantic about this. You got to deal with them, but it's one that they want. Most people don't like getting up in the morning and looking in the mirror and thinking they're doing something irresponsible. And that's the way we got the AIDS drugs down. And a lot of other things. We have been much less successful with snack food because there are more manufacturers. There are more players. So you have to have a different strategy there, because you can't have even 8 people agree to hold hands and jump off the bridge together without knowing somebody's going to burn it behind them. So I'm not trying to oversimplify this, but you can do this. We got a lot of, before the Agriculture Department's new school lunch guidelines, we got what is in most of those guidelines in a voluntary agreement with school lunch providers, plus an agreement to bring it to rural American, Native American reservations for the exact same price they were charging the cities. But it takes, you got to really, it's hard work. You got to be willing to do this and to be thwarted from time to time. But I do believe we can do more of that than a lot of people do, based on my experience. Thank you all. Give them a hand. They were great. And all of our flacking, we don't want to be an Anya's IPO. We want you guys to make all the money. Just go on and do it. Thank you. Bye-bye. Good night.
Esteemed guests, thank you for joining our Health Matters Town Hall this evening. Your participation is greatly appreciated, and we invite you to attend our morning workout tomorrow with Sydney Benner from 7 to 7:30 a.m. on the Emerald Lawn. Preceding the morning workout will be a Health Matters networking breakfast from 7:30 to 8:45 a.m. on the Rose Lawn. We will begin our Health Matters Activation Summit at 9 a.m.